Good evening all. My name is Dr. Anup Agrawal. I am an interventional cardiologist at Care Hospital, Banjara Hills. In this 53rd session of the Weekly Huddle, I am joined by my co-host, Dr. Praneeth Palamari, who is also an interventional cardiologist at Care Hospitals. We do these sessions every Wednesday at 7 p.m. where we discuss various topics, mostly clinical, but sometimes not directly patient care, but things which are indirectly related to it or our basic lifestyle. Last Wednesday, we completed 1 year of our session where we have done 52 episodes, and barring the first 8, all others have been recorded and they show up on YouTube and podcast. In the 52nd episode, we discussed about the mode of education itself. And my intention was mostly to talk about how the new age learning is going to be amongst us as medical professionals, particularly in relation to continued medical education. We understand that there is a certain teaching and learning pattern in our medical school, which is early on theory based and later on practical based, but then the pattern of education or teaching changes during residency, fellowship, and subsequently in our professional life, where very appropriately cardiology work is considered practice because we keep learning and that learning never stops. My intention or my focus on the discussion is mostly towards this part of learning, towards the later phase of our training and then in our actual professional life, in terms of how we consume knowledge, how we keep ourselves up to date. And in the current era where COVID has kind of imposed upon us to talk on a more virtual platform or to learn more on a virtual platform, be it CME, be it interactive sessions like these ones, or be it debates or discussions or whatnot, it is natural for us to think that as we go further, whether COVID stays or goes, the mode of education is going to change. This webinar based education platform is going to stay. There is no doubts about it. In which form, in what, that is what I think we should discuss, because going forward, we need to recalibrate our educational tools accordingly. What will happen to those classrooms? I don't know. Whether those physical classrooms or those auditoriums, whether they will continue to cater or impart education the way it used to do pre-COVID, I have no idea. And then what will happen to models like this weekly huddle, which we have been doing for 1 year? So once COVID settles down, will discussion like these on a virtual platform still hold value in our learning or in our thought sharing? I don't know. So I titled it as the new age learning, where we are moving from chalks and boards to now a webinar based platform. Where does the truth lie or where does the future lie? I don't know. Last week we discussed about it and we extended beyond our standard 1 hour. We actually discussed on it for almost 80 minutes. And the discussion continued for so long that I had to continue it on today's session as well, which is part 2, upon suggestion of many of the attendees during the last session. So we are going to continue today's discussion, particularly related to education, and I don't have any particular case scenario to be discussed. Feel free to share your thoughts about the mode of education that both the sides, where what is that you do to consume knowledge and what is that you do to teach others. How is it going to work around in the current context? I always start the huddle discussion asking opinion from my co-host, Dr. Praneeth, and then I go down the list and invite others for their opinion. It's a slightly off the topic discussion, so we are okay to take some detours and we are okay to share our thoughts in whatever form it comes. So Praneeth, you were there during the last discussion and we were discussing about the change in thought process, both amongst teachers as well as among students. And when I say students, I don't necessarily mean medical students. I mean me as a student when I'm learning and me as a teacher when I'm imparting knowledge. So last time we were discussing, and I think Dr. Shankar and Dr. Somaraju both kind of pointed out a shift in the culture, both from the teacher standpoint as well as from the student standpoint. And that certainly reflects a little bit on the webinar platform as well, be it the attendance in the classroom or be it attendance in the webinars, interaction and whatnot. So Praneeth, tell me what were your key points from the last session, and what do you want to add in this session regarding the education, the mode of learning per se? Praneeth, you take over, and then I will invite other people to join.
Yeah, good evening, everyone. So, Anup, I got what you got stuck with that question that you asked, that why the the postgraduates do not join the session, or why the attendance is so poor. I find that there is a gross discrepancy between what we practice daily versus what is it there for their exams. As a student, their goal would be to get the uh, pass out of the exam, get their degree. That is their intentional for that 3 years of training, and the entire focus would be to how do I train myself, or I tune myself so that I speak the language which I'm supposed to say in the exam, rattling those song that you have to sing while describing the murmur or those findings, etc., which are a must. And the exam patterns over the last few years hasn't changed, and still it is the same. From MBBS to MD to DM, it's always valvular heart disease, which is kept as a final exam where there are clinical findings which can be discussed in the case. But when we look into clinical practice, coronary artery disease is something which is the commonly seen scenario, or the bread and butter for every physician or cardiologist who is practicing. So there is that gross discrepancy. And when we talk about these things, if the discussion does not involve something which is being asked in the exams, then I don't have something to have an interest to listen to it. And yes, these are practical and useful for your practice, but first intention for me is to pass the exam. Only then I can listen to all these things which will be useful in the clinical practice tomorrow. So that is where I think is the discrepancy which leads to the lesser attendance. If that discrepancy can be resolved, and whatever we are talking, if it is equally useful for practical and other things, I believe will make a difference. That is my thought process on this.
So Praneeth, I have a question. In fact, I have, let me see how many questions I can deduce from what you said. So do you think that the exam question should reflect a similar proportion of your clinical practice? Do you think that is how exams should be? If you see 80% CAD or coronary artery disease, do you think exam should also have 80% coronary artery disease?
At least it should come into the picture that coronary artery disease could also be one of the cases which can be discussed in the exam. Like I've been here, or my education is completely in Hyderabad, so coronary artery disease is never a case, either in MBBS or MD or DM. It is by exception, it is never kept. And so I need not read for coronary artery disease. But if I have a possibility that it could come as an exam, and if I am forced to get this question, then I will equally look into those things, and that kind of gives me an interest or intention to listen to all those things and get updated myself, which is not the case.
Okay, and if we have to go beyond fellows who, so you, what you are saying is, I at least buy the idea that, okay, that may be true for fellows or residents who need to take an exam. But let me put you on the pedestal. You don't have to take an exam.
Yeah.
So give us 1 to 2 minute overview of how you consume knowledge, let's say in the last 1 year. how did you consume knowledge to keep yourself up to date?
Again, it's the same thing what keeps me interested or which will make me a better person in my practice, like the topics which are relevant to me in relation to cardiology or surrounding subjects, and something which are useful to me, I am interested to join and get involved, and with an intention to learn and expand my knowledge, versus something which is not that relevant, though it is an important topic. You are not that inclined. Like for example, COVID is something which cardiologist I'm not very much interested, or because I'm not a physician to treat primarily COVID, but with the pandemic going on, or the questions which are coming on, or people asking you questions, you are forced to get yourself updated every day to update your knowledge so that you can cater to the demands. So for me, where there is need for me to learn few things, I would put my energy and get involved in those sessions, and put my energy, or else again, my interest is also is less to other topics.
So give us at least two places where you have sought knowledge in the last 1 year, be it COVID or be it outside of COVID. Give us an idea. If you want to learn something right now, what is your go-to place? Where do you consume knowledge right now? Do you attend a classroom? Do you attend webinars? Do you read textbooks? How do you consume knowledge?
With the advent of internet, almost everything is available on your smartphone or your laptop, and the information is there everywhere. So the go-to place for me to find information is the internet. You look into the journals and find the information, you search for anything, and you get all the data, whatever you want, and you go through the relevant articles or things.
So, and by internet, you mean Google, or by internet, you mean PubMed, or directly to the journal website themselves?
Yeah, from Google or PubMed to the journals and respective websites.
And you think you are able to use that knowledge to translate into your clinical practice?
So far, yes, I'm satisfied about whatever I'm doing.
Okay. In 2 minutes, if you could share your thoughts about how did this weekly huddle discussion affect or modify, or in whatever good or bad form, your clinical practice?
So the weekly huddle was definitely useful to me, because the theory is something which is different, and uh, practical application is something which is different. So though we read about all those things, but for a given patient, making a decision based on all the information is something which is challenging. When we are discussing a particular case and the various scenarios of how and when, that is where the beauty of weekly huddle comes in, key all those minor details are brought up. For me, my practice has definitely been better. I'm more confident now to suggest something or prescribe something or order an investigation. So for me, it definitely has changed the practice. As I said, more in terms of practical considerations rather than theory, because theory is uh, available everywhere.
Perfect. Thank you so much, Praneeth. I'll move on. I remember last time when we were discussing, Dr. Somaraju mentioned that how the new age learning has to be more comprehensive, which means we can't just have doctors and doctors sit together and teach each other or talk to each other. There has to be a more comprehensive assessment of learning. And in that so-called inclusive nature, we need to have nurses, we need to have technicians, we need to have psychologists, dietitians, physiotherapists, psychologists, you name it. The idea here is that while we can teach them, there is equal opportunity for us to learn from them. Pre-COVID era, or the good old days, I would say, where the learning would come bedside or the learning would come on the hallway when you are talking. Now things have changed, and once COVID goes away, I don't know if we are going to go back to that same aspect or not. So Salma has been here joining us for our huddle session at least Salma, correct me if I'm wrong. I believe you have attended at least 10 huddle sessions. Give us your viewpoint. You, from a heart failure nurse standpoint, uh, entertaining this huddle sessions, which are mostly doctor oriented. Tell me what the huddle has done for you. How do you look at it? And what would you tell us that how can we be more comprehensive in terms of education that Dr. Somaraju was telling us last time? How can we learn from you, or how can you learn from us? Salma.
Yes, sir. First of all, very good evening to everybody. And I thank you all for giving me this opportunity to speak, learn, understand, hear everything from you all, with people with such vast experiences and all. So I would like to put one point first. As you said last time, Somaraju sir was saying that, yes, of course, comprehensive learning makes a lot of difference, as you said, sir, because if I have to understand, like if I take a bedside scenario and if I really want to understand whatever you want me to execute to the patient, like you order some medication and you want me to give it. And if I really don't know why you are intended or why you have planned to give that medication, I might not be able to really fulfill that requirement that you want. Like, for example, if there is a diabetic patient and he gets a routine medication of oral thing, but suddenly his sugar spike and there is a need that he was supposed to start on an insulin on a quicker basis. And if I really don't realize the reason or cause to start or the point where to be started, I will not have an idea and I might not discuss it with you. Rather, if I know why you have been started and if I can discuss the case with you, might be we can work together in improving our knowledge and helping the patient or whoever is the stakeholder for it. So that is one thing. And yes, of course, Huddle has helped me learn a lot of things. As Pranita said, in theory, whatever we nurses especially get is something like a copy paste job. Like if I want to do something different, my tutor or educator might not permit, because she would obviously say that your syllabus or your council doesn't want papers to be submitted like this. If there is a Cardex form needed, there is a Cardex form needed. Whether it is really intended to be used in practical life or not, that's a different matter. My examiner would want me to put the format in the same way, so I will have to put it. But whatever we used to do it in the in the initial days, in the practical learning days, we hardly had it in theoretical studies. And what we are really doing now, there was nothing related earlier. So that is where this difference comes. So if we have a change of learning, we will obviously be updated and have a lot of benefit. So I like to put another point. Like, I have been the student of Care College of Nursing, the first batch. We earlier had schools of nursing, but Care College of Nursing started and I was one of the students of the first batch. So those times, Somaraju sir and Rajiv Menon sir used to conduct classes in our seminar hall. So one fine day, our principal said that you are no more going for that classes. So when we asked, she said, like, you are not supposed to be trained as doctors. You have to work the bedside and you are only nurses. So you hardly will be benefiting from that. But then later on, we got to know from our teachers, lecturers, that, Somaraju sir insisted that we are all supposed to attend the class, so that if we hear 10 words, at least one word goes to our brains, and might be that we can apply it in the practical scenario. So yes, of course, that really makes a big difference. And also, there is one thing that I would like: these things like this, the huddle gives us a chance of getting things revised. So unless we get a revision, we might really not be able to remember or implement things. So this really has a very big help or effort in improving ourselves. And yes, of course, as last time Praveen sir said that school days were something different, or our early learning times, I should say. We had we were made, or we were trained in a way that we prepare our own notes, we write it, and then we submit it to our teachers. And we also used to give something like lectures or seminars or something. So that, at least I feel, is missing now because of the COVID. And I really wish that we get back to that chalk and duster kind of learning, at least for some part, because practical cannot happen in a virtual kind of thing. And I really don't know how many people will be able to hold on their interest or hold on their focus unless they really get teachers like you who can involve us in the discussion and learning.
So Salma,
So this is what I would.
Salma, you brought up few points, and I will ask few questions to you, and then I will continue those questions to my other attendees as well. So,
Yes, sir.
do you believe that nurses should attend basic medical classes which are meant for doctors? Do you think that adds value to nurses?
Absolutely, sir. Absolutely. And I actually, if we go back to the days when we were trying to establish HF clinics, the only challenge why today I cannot have a team in HF clinics from the part of nurses is, every nurse used to ask me, even today people ask me, my nursing colleagues, they ask me, what is the benefit that you get when you are in a HF clinic? Will you be able to earn more in matters of monetary ways? Or will you get a job, better opportunity outside, in other countries and all? So it becomes really difficult to make them understand that, it is, first thing is your interest. And the next thing is the zeal to do something new or put yourself on the growing part. So I think if we really nurses get a chance of getting that medical education in a detailed part, we will obviously have more of interest and more of benefit. And we might be able to put up things in more practical way. Nurses might be doing things with expertise, but they might not understand why they are doing it. So if we have a basic knowledge, we obviously will be benefited a lot. And I wish somebody could get this into the nursing council and have it as a curriculum so that nobody goes away with it.
So here is a follow-up question to that. You said that this was something which was taken away from you guys early on during the nursing education, and this chalk and board model, if we be very pragmatic, highly unlikely to return in our regular clinical scenario. So my question to you is, if you think it adds value, if your fellow nurse asks you that, where do I get myself involved with these things? Do you have a resource as a nursing? Do you have a resource where you can guide your nursing students to go to XYZ, where they can get these kind of teaching or knowledge or be a part of it?
Yes, sir. Like, in fact, not that really pure kind of chalk and duster thing. But yes, because in care, even today, like even before the COVID scenario we had, there were regular sessions conducted for nurses, like continuing nursing education program, which I believe we also have for doctors. There every week you have some case discussion. So there was something like that even for nurses. But the problem or something that disinterested me from that sessions was, we were hardly discussing points which were really important or which were something dealing in the practical scenario. I might have a nurse educator who might teach me the similar hand washing technique. I understand, again, repetition or practice or revision is important, but yes, there should be something beyond that. But that was not happening. So if we really have to get that, nurses can do something like either they reach to their nursing superintendent and the superintendent collaborates with some of the doctors who can help us gain the medical knowledge as per, and then try to put on the practical things that we are doing. Like for an example, if we check blood pressures, we still have the manual kind of blood pressure checking in many of our clinics. But I have witnessed, nothing offensive about anybody, but I myself have witnessed, like the way we put up the cuff, the way we used to put up the cuff in the initial days, and now when we come into regular practice, nobody does it in the same way. It is all wrinkled, clumped up, the tubing doesn't lie parallel to your cubital fossa, etc., etc. So might be if we try to correct ourselves or implement that thing in practical scenario, that would really have us a great help. But yes, I agree. It might take, somebody might have to take it up as a challenge and try to take an initiative and do it.
Thank you, Salma. Thank you so much. If I have any other questions, I'll get back to you. Thank you so much. I'm going to move on, and let me invite Dr. Srinivas, sir. I hope, sir, you are able to hear me. We are talking about mode of education in this session, and Salma brought a few points. Praneeth brought a few points. I want to ask you things which we were discussing with Salma and things that Dr. Somaraju last time brought up. This whole concept of comprehensive education, where we cannot just live in our own silos and a doctor talking to a doctor. And Salma mentioning that nursing and other ancillary staff, it is equally important for them to understand our thought process, which means they need to be involved in our education. And the new world that we're talking about, COVID, webinar, all those kind of things. Salma mentions that pre-COVID there were weekly sessions for nursing, which was happening, which of course is not happening now. She is optimistic that it will start after COVID is gone. I am not optimistic. I think that world has been recalibrated, and now I doubt that something like this is going to restart. Similarly, we used to have these sessions in our cath lab as well. I don't think, I'm not very optimistic about it. So Srinivas sir, what do you think? What is this? What do you think is the new era of education that is going to be around, particularly with regards to paraclinical staff? And do you think, can you suggest a new model? How are we going to make this work? Srinivas sir, if you can hear me, please.
Yeah, Dr. Anup, no major changes actually. What Dr. Somaraju sir had taught us, I mean, that should be continued. It should be always a team approach wherein all members should be included in the management of the patient, right from the nurse who comes for rounds along with us and the nurse who's going to stay in the wards after our rounds, because they are the ones, once we make a diagnosis, they are the ones who follow our orders, so they should know what treatment is being given, why it is being given, what are the things to monitor for. So unless we involve them actively in our decision making and our treatment plans, finally it won't work for the patient. So it should be all inclusive, and right from the wards to the cath lab also, like where they manage all our emergencies. If we do a successful angioplasty, and then if they don't follow up the patient in the cath lab, wherein they could end up having a groin hematoma. Sometimes patients were discharged with the sheath not being removed. Now it doesn't happen, but there were instances when sometimes it did happen. So nothing should be taken lightly. We should make it a point that the next day the groin is examined. We shouldn't take it for granted that the sister has seen. We do go through all this process, but if we do it as a routine, as a daily uh, thing, I'm sure all our juniors will follow, and that is the only way forward. Yeah.
So, sir, the question here is, what you are saying is the requirement. I think that requirement undoubtedly needs to be there. The question is, how can we execute it? Because in-person teaching is almost stopped right now. Whether it is going to resume or not, we don't know. We are talking on a webinar, on a virtual platform, where a lot of attendees, I haven't seen their faces ever in my life. So how are you going to teach your cath lab staff how to hold a groin? In person, you can't do that these days, at least right now.
No, I mean, we are still doing the procedures, right? So when we go do our procedure, we still communicate with our staff, and maybe the number of cases have come down, but the instructions would still be the same. Like someone who had a left main disease, you would still discuss what all to look for. Even while removing the sheath for a patient with left main, you would watch for hypotension. You wouldn't give the same instructions as you would for a patient with a regular angioplasty. So definitely, even though the number of cases would have come down, our approach to sick patient would be the same.
Thank you so much, sir. Let us continue our discussion further. Let me ask Dr. Shankar. Dr. Shankar, last time we heard you about your thought process regarding so-called old school education model and what we are doing right now, particularly with the diminishing quality of what we are doing. I want to get back to what Praneeth said, and I want you to give your thoughts on. Do you think our resident learning or our early education is so much exam oriented that we tend to focus our education more on that rather than learning clinical medicine or practical medicine or interactive medicine or those kind of things?
Good evening to all. First of all, I congratulate and thank Dr. Anup and Dr. Praneeth for conducting a first session in this second year of our huddle. A nice question has been asked regarding, see, the earlier last huddle, last session of the huddle, I discussed about our type, what type of education we had in our olden days. In the modern era, we have to transform ourselves into a digital doctor. I mentioned, I stressed upon the same point, because nowadays we are having access to many search engines, the WhatsApp, the Google, PubMed, so many up-to-date Medscape, Mayo Clinics, so many are there. Some are paid, some are free apps are there. So students have got a lot of access to learning. Earlier we had lecture classroom or lecture halls, bedside teaching, journal clubs, and the weekly discussions in the early morning of every week. So pulled up interesting cases in any of the wards are there. Those cases were discussed on a weekly basis with our expert teachers. So that type of education we had. But now, because of access to these smartphones and the search engines, and the artificial intelligence has crept into our medical curriculum. So both the teachers and the students are not interested in learning, because I last time also I stressed that if you teach, I forget. So if it is preserved in the in WhatsApp or in the files or in the documents, so he will recollect now and then. If you show, see, even if you want to show also, there are plenty of videos are there. If you want to see any procedure, see, earlier I want to remind Dr. Somaraju sir also here, in late 90s, late 80s, and early 90s, the streptokinase was introduced into the market. Though we were the first medical contacts, so sir was interested in to teach us. So he invited all the first medical contacts who are looking after the cardiac cases. So because in the 1 hour after the myocardial infarction is a golden hour. So in that golden hour, if the patient comes to the first medical contact, the first primary care physician, so patient will be benefited. So that was the goal of our teachers. So holistic approach was there, and the betterment of the society was there, and their goal was different. But now it is commercialized. That Dr. Somaraju sir also agreed last time. So he invited all of our those who are interested in maintaining the ICUs, cardiac ICUs, especially because we were not having the cardiac facilities. We used to go to Hyderabad. We used to go to attend the conferences. I became member of even Cardiological Society of India. Even now they are not allowing physicians, but that time I was made this life member of this Cardiological Society of India. I was a member of this Indian Society of Electrocardiology, ICC, so many things, because I was interested in cardiodiabetology that time, because that time it was our bread and butter for physicians. So I was compelled to learn the cardiology also, apart from electrocardiogram. Then even I was compelled to learn even echocardiography also. Dr. Raghu is my classmate and my teacher also. And I attended a workshop, level 1, level 2, level 3, conducted by Dr. Krishnam Raju, A.V. Anjaneyulu, and Dr. Raghu in the same care hospital. So I was given a certificate also in echocardiography. Then I attended many classes. I showed some interest, and I purchased also White Elephant, this echocardiography machine. And I started learning on the, and patients are benefited a lot. It benefited me also. So that type of learning was there earlier, but now there are so many search engines are there, videos are there. We can see, we can learn and all these things. That time we were not having only the teachers. They told me that you purchase the echocardiogram machine only, then only you will know how to position the probe and all these things. Otherwise, even if you teach also, you cannot learn. So even though they involved me also, it took a lot of time to learn. So I purchased the machine and I learned, and for the past 10 years I have been doing. So this is it depends on the interest of the teacher and the students. And regarding this present situation is, because of the availability of all these things, the students think that this is available in the internet. We can search for it. We can get any number of n number of articles, n number of information, n number of videos also. Why should we learn from this hurdle or bedside teachings? See, here what we are losing here in the modern education, one is the doctor-patient relationship is lost. There is no human touch at all. That touch, what we use, we were told by our teachers that human touch is essential for the healing of the patient. That touch has been lost. There is no proper relationship between the doctor and the patient. That relation has been severed. So here, the modern education student is very much exam oriented. Suppose if you give MCQs, he will prepare for the same. If whatever the case is kept in the examination, they will prepare for the same. And nowadays, who will be the examiners? What is his mode of asking questions? Also, they are now acquainted with. So now the education, they have lost they are not at all involved in practical education. They know theory well. They know procedure how to do, but they are not involved really. That's why. So I told last time, if you teach, I forget. If you show me, I remember at least. If you involve me, then only I learn. So here in this learning process, they have lost this component where their involvement is very poor in the management of the case. So with this, I am very much thankful to Dr. Anup.
Sir, we lost you momentarily.
Okay. I am
Yeah.
very much benefited by this huddle, because even if I get one point extra to my knowledge, I am very much benefited by this, and indirectly it will benefit my patients. So thanks. Thank you, Dr. Anup and Praneeth. I really appreciate your conducting a huddle. People like me, especially primary care physicians, where we are dearth of learning. So we will be benefited a lot. And as much as possible, you involve the specialists. Suppose when we are dealing with any case of arrhythmia, involve EP specialists. Many are there in Hyderabad. So even Dr. Vivek, he is from Delhi. He participated in our huddle. So during this pandemic, we have got a boon in disguise. We can involve n number of specialists those who are expert in the particular field, we can involve them, we can learn a lot. Thanks for these huddle sessions. It is helping me a lot in my day-to-day practice. Thanks a lot.
Thank you, Shankar sir. A few points I have noted, which I will ask my other attendees this question. My next question is open for anybody. If Dr. Gopi Krishna or Dr. Ruby, if anybody can hear me, you can please feel free to unmute and share your thoughts. Dr. Shankar mentioned about online education being a boon, and then there are n number of websites available, videos available, and whatnot available that people can browse through, things for which during Dr. Shankar's era, they had to make an extra effort to go and sit in a class and hear what people are saying, versus now you can just go online and get that education. My question is, when this information has become so easily available to us, are we consuming it more than what we were doing it previously, or this ease of availability made us more complacent and we are actually consuming it less? In a way, my question is it making us more knowledgeable? Is it making us less knowledgeable? Are we becoming too laxed that we are, there is too much of information, we don't know where to go, and we end up being that confused, if I may say, that famous donkey who has got, you know, various options and is not able to choose from which way to go. Is it really something which is enhancing our education, or we are just happy that it is available to us? My question is for either Dr. Gopi Krishna or Dr. Ruby. Anybody can please unmute themselves.
Yeah, good evening,
Yeah,
everyone.
this is
I'm Dr. Ruby.
sorry.
Okay, let Dr. Ruby go first, then I'll come to Dr. Gopi Krishna. Dr. Ruby, please go ahead.
Thank you, Doctor. Yeah, I'm Dr. Ruby, and I'm a family physician by profession. And I was introduced to this huddle by Dr. Debashish Saini, who is also a family physician. And we are all part of the distant education department of CMC Vellore, where we run an extremely benefiting course called as a postgraduate diploma in family medicine. And when this COVID came, and when hands-on teaching was no longer possible, I was quite skeptical when they started these online contact programs. And me myself, not being very good at technology, I also, was very skeptical. I didn't join for the teaching sessions and during the first few months. But later on, as we passed through this last 1 year, and we had 3 contact programs, that is for 3 batches, that is once a week every Friday, it is for about 4 hours. And I realized how much we can gain out of this online courses. I think sky is the limit now. And even the responses from the students that we have been getting, they are much more happier with these online programs, because they are all doctors who are already working, who are doing this course. So they find that otherwise they would have to come to the centers for 13 days. They had to take leave, stay there, because it is run in 18 centers around India. So they had to come to different centers, the area, according to the states and neighboring states, they would come to a certain center and have the class. And here, because we have about 300 to 400 students at one time, we have breakout rooms. That is each center, like Kerala has a center, Delhi has a center, Nagaland has a center, Assam has a center. So each facilitator of that center goes into the breakout rooms of these smaller groups. So it is more or less like we are meeting our own students again on this virtual platform. And there is nothing that cannot be taught on the virtual platform. I think our education system has to change that in a way that we shouldn't be exam oriented, but what we learn, what is useful in our practice is more important. When you said that there is so much of information available, that is the whole problem now. There is so much of information everywhere, but the wisdom to apply that information in the right way is what is lacking. Like we have seen in the COVID management too, how certain drugs were just used. Everybody is just giving a cocktail of drugs in order to not thinking about what that it pinches the pocket of these patients as well as the side effects of the drugs. So I think it is a wisdom that we have to implement here when we have so much of information. And I think in our breakout rooms, we do have one-to-one contact. We have case scenarios which are so useful. It is just like a bedside teaching. We have case scenarios which are structured in such a way, and the questions are asked, and every single student or the learner, I wouldn't call them student, every single learner has to participate in the discussion. We put up our case history and we ask questions, they ask questions, different people come up with different opinions how to manage it. And I think it has been really, really wonderful. And I think sky is the limit. And even the responses from the learners has been that it is much more useful for them. It is much more easier for them because they don't have to take leave. But actual physical contact program to learn certain skills is also important, which we will have for just a few days when God permits, when the corona comes down. Thank you very much. And I'm really impressed by this hurdle because I find that though it is mainly a cardiology circle that is conducting this, you have, what we have been teaching in family medicine, that is exactly what you also believe and practice. When you had that session on wayside consultation, I was quite impressed by it. And the way it was taken around and all the discussions that went on. And even though I'm not a cardiologist, I don't mind learning about cardiology because I may not practice active cardiology, but still that information which I learned will be useful because as a family physician or as a doctor in the family or among the friends circle, there will be people who come and ask me for doubts and I should be able to give them the right advice. So I think any knowledge that you can gain. In a way, I'm not able to travel because of various reasons. I cannot go out to other CMEs and late at night. So I think for me, this is the best thing that can happen is these online platforms of webinars and discussions like this. Thank you very much for this help.
So Dr. Ruby, before I let you go on your thoughts, I have few follow-up questions and comments. First of all, Dr. Somaraju requests that you please share the link of the courses that you're talking about. I'm sure that a lot of our huddle attendees would love to at least get a taste of what you guys do. Second is, I'm going to play a little bit of devil's advocate about your online sessions. And before I do so, I do want to highlight, you mentioned about the huddle being conducted by cardiologists. It is true, it is being conducted and mostly attended by cardiologists. I'm an interventionalist. My field of interest is something called TAVR or transcatheter aortic valve replacement. And I feel very proud to say that in last 52 sessions, this is the first time I'm uttering the word TAVR. To take home this point that we have tried to keep the discussion topics for the huddle something that every single practicing physician should be able to get the points in their regular clinical practice. The whole super specialization that is for us, that is not what we designed the huddle for. So while I never discussed point that interests me directly, I feel very proud of doing so. So the question about your online session, I'll give you an example, and then I'm just playing devil's advocate. You give me your response, quick 1 minute. One of the faculty posted a picture on the Twitter saying, this is one of the negative aspects of being a faculty on a virtual CME, because now you have to take STEMI calls. In a way that she was about to deliver a lecture, but she got a STEMI page, so now she had to go and do a primary angioplasty. In the last few days, we had ESC, or European Society of Cardiology meeting, which happened for 3 days, which I attended. And I'll tell you, because the sessions were happening at the same time when I was doing something else, I was not very much attentive to the online session because there were a lot of distractions around me. A lot of the times I was watching those sessions as I was at work. So yes, I did not need to take the day off from the work. But at the same time, I wasn't that much involved in the meeting. Now I can understand there are online workshop model where if you don't get involved, you don't get the points. That I agree with. But don't you think these online sessions, while they have increased the reach, the overall quality education that people end up getting from there, I don't know how many attendees right now are actually literally paying attention to every single word being spoken. Don't you think that is the negative aspect of this so-called online CME setup?
Yes, that is one of the negative aspects. But then we insist that you keep once a week, you keep 4 hours just for this purpose. And in adult learning, it is not we trying to teach them. It is their own need to learn. So that is why they have joined the course. So it is for their benefit that we are saying. But still, many of them are at work. Because we have an attendance that has to be taken. We take a picture in the breakout rooms. We ask everyone to turn on their camera. So even otherwise, the Zoom takes the attendance, but still we insist that everyone turns on the camera in the breakout rooms so that we can take a picture. But still, a few of them won't turn on their cameras. So we know that they are not. Once somebody turned on the camera and he was driving a car, and I was discussing some questions with him. And I told him, no, I think it's okay. Even if you don't take part, please be safe. So that is one of the disadvantages. And even we as facilitators, we are advised to take leave and not, multitask on that day during these 4 hours. When you have still we do have facilitators in between a session, there will be calls coming. They switch off the call, continue with the session. And we always have a backup. Like if one of the facilitator is busy or something happens with the or internet or connectivity or anything, or somebody has to take a call, we always have a backup so that we discuss with each other beforehand that in case something happens to me, in case I am busy, then please continue with that. So without a hitch, the session is continued so that the learners are not in any way compromised.
Perfect. Thank you so much, Dr. Ruby. I'll get to Dr. Gopi Krishna. If you could please unmute yourself and share your thoughts about the online education model. Good, bad, ugly. What do you think?
Definitely, it is good. In my view, definitely it is useful because uh, continuously we are involved in a clinical work and routine practice rather than concentrating on education, because we are not having students or we're not having so many colleagues, fellow colleagues who are practicing cardiology with us. So, and even in the peripheries, like our place, most of the doctors are busy with the OPs rather than interventionist and other clinical works. So most of them are not interested to share their knowledge and exchange the ideas. The thing is, the sessions like these, definitely we can able to update ourselves what's going on in the cities, what's going on in the world, and what are the problems they are facing in day in and day out in their routine practices. Whether we can able to reach them or whether we can able to apply those things in near future in our places. Whether we can really helpful for the patients in emergency situations with the new techniques. All these things are benefit to us, especially if we involve continuously with this type of sharing sessions where we can share the new updates and everything. So definitely coming back to the education pattern, uh, if we consider that only online mode, other modes, the education pattern is definitely not going to help us in improving our complete exchange of idea, or to improve our clinical skills, to improve the nursing skills, or to improve the doctor-patient relations. Nothing going to change much with this type of things, but definitely we can able to have more and more information. We can able to have updates. We can have more and more things to share, and we can help other colleagues to take care of the newer modalities. But the information is flooding with the internets and these available resources from so many WhatsApps and other searches. But coming to the comparison with the olden days, we have more clinical touch or human touch with the patients. Along with that, our teachers used to make us learn the interesting sessions. Like when I was a student in Osmania Medical College, even there we are flooded with the knowledge in the form of a libraries where we used to have thousands of books. If I have found a good time, I can go and spend with the books, and I can search whatever the topic interested. I can go and search that type of, the special books which are intended to for that special learning. But the thing is not the correct way of learning at all, because practical things are much important. In Ismania, we used to learn more and spend more with the books rather than with the practice, because see, the technologies are not available with us, especially coming to the discussion of some neurological case where there is a headache, where there is a focal neurological deficit. If we want some information, extra information from that, only clinical discussion, of course, our learning used to end there only, but we cannot able to learn what exactly thing happening inside the brain, where the lesion is, where the available technology like MRI, CTs, which are not available use easily there. So, after coming to the care, I used to have some special, I have seen some special education pattern there, where I used to have a clinical radiological discussion, neuroradiological discussion, rheumato radiological discussion, or interdepartmental discussion, etc. there. So, especially, I used to attend the radiological sessions also, where they used to discuss like a ring enhancing lesions. They used to present a case scenario like a patient presented with the focal seizures involving the hand, and after that he developed some behavioral abnormalities like a focal seizure extended into complex seizure. Such type of discussion, clinical discussion presentation used to there. Then they used to show the MRI picture. Then in MRI, you used to see, okay, where the lesion is there, okay, in the cortex, and it is especially sensory cortex, and which area it is there, either it is in the upper limb area, or what is the DD for that ring enhancement lesion. So they used to tell completely there only. The student used to, when the teacher used to ask the question, the student used to share his possible differential diagnosis. Then the teacher used to correct tuberculosis or neurosis, like that one by one. So many points we used to get in the clinical bedside scenarios only. And the same pattern, the other pattern I learned in the care is like see, my guru is like a Somraj sir only. Sir used to make everybody like nurses and everybody used to teach in a similar manner. He never used to consider he is less, he is more, like more important, less important, nothing like that. So he used to whenever uh, we come for the round, sir comes for round, or somebody else comes for round, they used to discuss entirely, starting from the, if suppose MI case is there, what is his clinical picture, acute coronary syndrome, whether he, after thrombolysis, how the patient behaved during thrombolysis, whether he had arrhythmias or any other problems or hypotension. And after that, tomorrow, after consultant comes to the bedside, the nurse used to present everything. So patient presented like this, immediately got relief of his pain after thrombolysis. There was no arrhythmia, and we prepared him for angiography. Sir, serum creatinine is good and is not in a failure, so patient is almost ready for a next procedure. So similarly, I am applying the same thing here. I used to teach my nursing staff ECGs, how to evaluate the heart failure patient, how to stabilize the acute coronary syndrome patient, and how to prepare next day when I comes to know for angiography or something. So it will become like easy for me. So they, in fact, they help us in maintaining the patient. Otherwise, I have to look for all these things. By the next day, I have to find everything, case sheet, I have to search completely. My time goes for these things only, rather than if I train them nicely. By next day, when I reach there, they explain just nicely, sir, ST elevations are come down after thrombolysis, patient is stable, hemodynamics are stable, I have seen the serum creatinine is good, sir, patient in not in a failure, saturation is good, clinically is doing better, so he's ready. Then I just used to have like a superficial look, and wherever the points of interest are there, I used to concentrate there only, and it's almost like an easy job for me. So education system, even though with a lot of information through the these whatever the innovative technologies, internets or other form of therapy, should have a good teacher and a good education pattern and the subject of interest where to concentrate, and after that, like if cardiorenal syndrome you want to know, you should have exactly knowledge about the cardiology, heart failure first, then heart failure related other system involvement, then about the renal system, then cardiorenal, like that. So education, one is first by clinical methodology, then by technology involvement, and of course human touch, which is important. Then only we are going to have a good science in the future, and our patients will be benefited by most of these things.
Perfect. Thank you so much, Dr. Gopikrishna. I think you pointed out some of the very practical aspects of how we do our rounds. It's 8:05. Let me get back to Dr. Somaraju. We had to cut him short in his thoughts last time because we were running short of time. And while we are 5 minutes past our standard time, I would request Somaraju sir to share his thoughts and maybe for next few minutes, share his thoughts about what is the way forward for this online education and what else can we do within the realm of the weekly huddle, and also what we do outside of this as well, how to replicate a sound and effective education model. Somaraju sir, if you could share your thoughts on this.
Thank you, Anup.
Sir, we are not able to hear you. Is anybody else having audio issues, or am I the one?
No, we are not
Thanks
able to hear.
to connectivity of everything, and thanks to computerizing and knowledge availability everywhere now, facts of medicine are no longer difficult. They are available to everywhere and everybody. And now the issues are that we repeatedly used to say that we don't teach facts, we teach attitudes. And that patient-centeredness, student-centeredness, and community-centeredness. Having said that, unfortunately, while some of you talk about continuing to be educated in the present system, you must realize that everything changed around us. The requirements, fundamental requirements of medicine changed. Namely, the original medicine we all learned, and some of you are continuing to learn, is biological and clinical. But there's no longer enough. The health system. Now, the present day medicine and present day practice of medicine requires that we have to redesign the medical education and our training and everything. That requires that you have to be knowledgeable not only in biological and clinical sciences, but that's anyway basic. But we need to know other branches of science, technology, arts, and whatnot. Having said that, we need to know mathematics, we need to know physics, we need to know chemistry is biology, we need to know information sciences, we need to know sociology, we need to know teamwork, we need to know leadership, and we need to know management. Learn to manage. A managing physician it has to be part and parcel of medicine. And as I said last time, medicine is no longer doctors and nurses. Our playboyism type of medicine is gone, and it has to go. Like it is doctor centered. Now it has to be patient centered, person centered, student, community centered, and then we have to include all the people who are involved in delivery of healthcare. The COVID is interesting. While we talk about all the problems we are all facing in COVID, COVID as an experience also taught us something. The unsung heroes of medicine are heroines of medicine, namely the nurses, technicians, including housekeeping staff, and including administrators who are very, very positive about some of the things. They all have to be part and parcel of everything we do. I call this knowledge management inside healthcare organizations. And we have to form multi-specialty, multidisciplinary teams, and which includes all of them. And again, I call this knowledge management inside healthcare organizations. Examination system. The examination systems are never perfect. It's time that we talk about open book methods of examination, because knowledge is and facts and data are available everywhere. The older systems of education are no longer relevant. They have to change. And whether they change or not is different, but be aware of these inadequacies. And if anyone has any questions, I will be too glad to try to answer some of them. But presently, we are part and parcel of a system of education which is not suited to deliver healthcare to the community. What we all do in our super specialty hospitals, our ICUs and all that is tip of an iceberg. We no longer take care of chronic diseases, and medicine has moved away from tertiary care models of healthcare. And lastly, I just wanted to say that COVID gave us an opportunity to try to get back the trust we lost in public. But unfortunately, most of our private health, which is full of greed, and public health, which is full of, say, apathy, didn't take care of it. And we didn't use that to advantage, with a few exceptions. I just want to end here. Feel free to ask any questions you have. Thank you.
So we are 8:11, but I do want to get the conversation going for the next few minutes, unless anybody thinks that we should stop now. If anybody has got any questions, particularly for Dr. Somaraju, please come up. Sir, I do have questions, and in fact, I have so many questions. We can continue for another hour. I'll just ask you one question. Things that you mentioned, which are, knowledge management and overall healthcare learning outside of our comfort zone, which is talking about clinical medicine, patient management, and all this. You talked about the art, sciences, chemistry, psychology, and whatnot. And also going beyond the clinical staff, we're talking about housekeeping, we're talking about patients, we're talking about all this. My question to you is, do you think these feat can be achieved via online education tool? And if yes, do you think a speaker audience model is the way to go, or how we can institute it in an online model? Or you think you see a world where we are going to go back to a classroom model where we will like reenact what we were doing 2 years or 3 years ago?
While Anup, while we say the requirements or the content we talk about, luckily with the advances in computerization, advances in the methods of learning now, online, offline, and everything, it will be easier now to learn anything. But to put it into practice, we still need something more I already talked about. So then everything will change. Say I'll say the machine learning, artificial intelligence, all these things will come in, and then things will become easier to learn. And some of the so in our system of education, what all we went through, memorization and try to keep everything in your mind, and so that you can vomit out in the examination, all that will change. And so be ready for all that. And what is important is where do I get this information when I need it? And that world is now knowledge, and data is an open book now. And then how it is delivered, how it will happen, only time will tell. And again about COVID. While we go on worrying about COVID, it's the COVID that is created by humans. And we used to have COVID will end, but something else will come. We used to have a saying when we were students, bleeding always stops. COVID will stop, But what do we do with ourselves is the challenge.
Dr. Ruby, you have something to add?
Yeah, I think Dr. Somaraju is a perfect family physician because these are exactly the things that we teach. We are doing those topics on the online platform, like family physician as a leader, family physician as a counselor, how you manage your staff, your subordinates, your cleaner, how you can use them in a small setup, especially people working in the periphery, how these people can be used to help educate the patients, their bystanders, every time that you can use in preventing diseases. So these are the things that we focus, and we are doing all that on the online platform. While as a clinical skills, we have kept for the face-to-face contact program. So I think it is possible, and all these things are supposed to be included. If only it could be included during our undergraduate studies. I don't think we need to do a family medicine course, but I think I've been so impressed. I'm so glad that I did this course, and especially that I did it from CMC.
Thank you, Dr. Ruby. Thank you so much. If anybody has got any other questions or comments, please feel free. And while you gather your thought, I will get to Praneeth for his final comments. And if any of the attendees have any questions, we can still take one or two more questions. So Praneeth, take home points for this session. And my question to you is, while we are talking about knowledge management as the new phrase that I'm quoting what Dr. Somaraju said, do you think it is feasible for us to do a weekly huddle, particularly taking these aspects into account, like let's say doing one session only for nurses, doing one session only for psychologists, doing one session only for physiotherapists? And by session, I don't mean we educating them. What I mean is the same kind of interaction that we are having amongst doctors. Do you think something like this is feasible? Do you think it will be meaningful? And where we go from here, your final comments I would like to hear, Praneeth.
As we were discussing, or as we understand, right now that whole thought process of depending on one person should probably go, and each and every person in the team or in the management of the patient is equally important, right from the IMR to the concerned head of the department. Focusing particularly on a particular specialty like nurses or physiotherapists, I don't know how much practical it will be and how can we conduct it. So I'm not positive that we would be able to conduct a session, versus I would say that this platform which we are already conducting itself should be in a way where everyone can get useful information, which I think is still available. It's only a matter of time that people should kind of get a taste of it and then realize that there is something for everyone who participate in programs like this. That's what I could think of.
Thank you, Praneeth. Anybody else has got any final comments before we wind up today's session? Okay, if not, then I really appreciate you all.
Anup,
Yes, sir.
Anup, I just want to say, when you take a, I was talking about the past, and it has to be put into practice even in future in a different form. When you take a round in the wards, it has to be not only your postgraduates, but it has to be an undergraduate, it has to be a nurse, it has to be the rest of the staff, whoever is looking after the patient. Then only everybody understands what is expected of them. And I'm only just giving you how we used to take a round. Everybody has to be involved. Then things will change. I'll leave it here.
Sir, one question to that. While I totally subscribe to this idea of bedside teaching, I never used to think that there's going to be an alternative to that. I still don't think there is going to be an alternative to that. But as you said, COVID came, COVID is gonna go, something else going to come. Our thought process are changing, our ways of working are changing, whether we like it or not. That's how we are progressing towards. We are cutting trees, building and making buildings, whether we like it or not. That's how cities are growing, unfortunately. My question to you is, do you see or do you foresee the bedside model continuing in the future as well? I mean, there is a part of world which has stopped using a stethoscope now. Do you think this is something worth investing much onto it? Does it have a future? That's my question. While I love the idea, do you think this will continue for the next 50 years?
Well, only time will tell, but it will be in a, suppose you can't take routine bed rounds anyway while it's happening in COVID times, and but it will change. But while things will change, we'll have to adapt to those circumstances. Still, the required knowledge, the required experience, the required skills have to be imparted in ways which are different than what we can imagine now. And thanks to technology, thanks to computerizing, thanks to software engineering, thanks to advanced learning and machine learning, and it will be done in a different form, but the requirement remains the same, namely patient and person-centeredness, community-centeredness. The fundamental requirement of medicine is prevention. When the disease comes, we treat, but all aspects of medicine have to be addressed. But maybe with all these things now available, we'll be able to do a better job, provided we are willing to change, and we are willing to change the content of our knowledge and attitudes. Thank you.
Thank you so much, sir. It's 8:21. I would like to conclude today's session. Thank you all for your participation. As you all know, we do this session every Wednesday at 7, and the previous archives can be found on YouTube and podcast. We also have a WhatsApp group where we continue our thought discussion offline as well. So if you have not joined that, I request you to join that as well. There is a link which is there in the invite. I thank all of you for your time. We will be here next Wednesday. Hopefully next time we'll discuss a clinical topic, and then while I gather my thoughts how to make the weekly huddle more inclusive of our knowledge management or whatnot. So hopefully I'll come out a little bit more knowledgeable after this, and we will execute in some form or the other. Thank you all again. Good night, and we will see you next week. Thank you.